Pervaze once again. I have a pretty interesting case here, atypical treatment of patient with erythrocytosis on mechanical ventilation secondary to community pneumonia versus COPD exacerbation. These are some of the people that I worked with, Dr. Michael Lilly, Dhruvi Patel, and my attending Roy Deal. Could go to the next slide. No disclosure, so we'll go ahead and talk about this presentation. So this was a 43-year-old female, pretty young individual with pretty significant history of substance abuse, on Suboxone, anxiety, depression, COPD, no oxygen requirement at baseline, though the patient was supposed to be on non-invasive ventilation, but she was not compliant with those. History of previous pulmonary hypertension. She initially presented to us with shortness of breath, nausea and GI, nausea and vomiting, some GI symptoms for the past several days prior to presentation. There was some generalized swelling, initial labs, notable for chest X-ray, as you see on the right. There's some patchy infiltrate on the left side, as well as initial BNP, which was kind of elevated. UDS was positive for marijuana and benzodiazepine. So, we admitted the patient for COPD versus community acquired pneumonia. I started the patient on antibiotic and as well as systemic steroid and breathing treatments. Next slide. So, however, very soon after admission, the patient continued to be in respiratory distress. And as you see some of the examples on the top right corner, the initial ABGs, patient was in respiratory acidosis with CO2 retention, eventually required mechanical ventilation with intubation. Continue to the next slide. Her ABG continued to be somewhat stable, but did require pretty significant mechanical ventilation, respiratory support, including PEEP of, I believe initially PEEP of 18 or 10 with the, with PEEP of 18 around there, and tidal volume, we went as high as, I believe, 720, FiO2 almost 100%. So her requirement kind of stayed around there, and ABG improved, but continued to require that we were unable to de-escalate as far as vent requirement. Given her continuous respiratory requirement, we kind of escalated her antibiotic coverage, and pulmonology was consulted. We ended up going broad spectrum, including meropenem, atypical coverage, as well as antifungal fungal coverage with micafungin. We also had to continue to de-risk the patient, given that she looked volume overloaded and she looked swollen overall. So we were continuing that. Next presentation, next slide. So this is looking at her labs. This is specifically CBC. One thing I do want to point out here, obviously the WBC was going up and down. It could have been secondary to the steroid that we were giving her. But what you notice is her hemoglobin and hematocrit. Her hemoglobin went as high as 19.3. So this patient, non-compliant with the COPD regimen, initially presented with pretty high hemoglobin, and it continued to be elevated as well as hematocrit. So there was some hemodilation that was happening. So given her presentation and worsening respiratory support, we started to look at other causes of her ventilation requirement. So we had kind of talked with other care providers in our care team, including critical care, pulmonologists, and hematology as well, to kind of to see what else we can be doing. So, and this was kind of our last ditch effort to kind of see what we can do, because the patient was not improving and was on ventilation for about 5-6 days by this time. So we kind of tried something called therapeutic phlebotomy as a treatment for secondary erythrocytosis in patients with COPD. At bedside, we kind of extracted approximately 500 cc of 500 cc of blood, as well as started the patient on full dose anticoagulation. The patient was on DVT prophylaxis, but we went ahead and started full dose anticoagulation. We were also thinking the patient, since the patient is so concentrated, we stopped the diuresis. We started increase in free water. The patient was getting 2 feet at this time, so we increased free water intake in this patient. The other side that we kind of attacked was her pulmonary hypertension. So we started the patient on sildenafil to treat pulmonary hypertension. And given all this treatment, the patient slowly started to improve. You could go on to the next slide. So the patient continued to improve after that. As you see, as far as the tidal volume, as you see at the bottom, we went as high as 730, and the PEEP was pretty high as well as FiO2. But slowly, given the combination of treatment of full dose anticoagulation, possibly bedside phlebotomy that we did, as well as increasing the fluid intake on this patient, the patient eventually started to improve, and the vent requirements came down tremendously to the point that we were able to eventually extubate her and put her on a nasal cannula with optimal saturation. So the patient was eventually downgraded to med-surg floor on 2 liters, and she was doing well, and she was participating on physical therapy, and she was overall doing well. Unfortunately, we could go to the next slide. Unfortunately, the patient signed out AMA, and we were kind of bummed about it, but that happens. So, just a couple of learning objectives here. I want to talk about secondary erythrocytosis or polycythemia we see in the patient. Some of the causes, especially in this patient, hypoxia was a source, given the history of pretty significant COPD, and on compliance, the patient had pretty significant erythrocytosis, and that could have been causing hemodilation and increased requirement of vent settings. Next slide. The other thing that we kind of want to talk about is pulmonary hypertension. As we know, there's 5 classes of pulmonary hypertension. Specifically for this patient, it was group 3, which is secondary to lung disease, which we were kind of treating. But again, as internal medicine physician, as I am, patient with pulmonary hypertension needs to be followed out outpatient at pulmonary clinic to get optimal treatment and cared for. So again, we are trying pretty much what we can do at this time with this patient, and we tried sildenafil. I'm sure it kind of helped her come out of the acute phase that she was in. But again, this kind of patient needs to be followed up outpatient with tremendous care, and compliance is the main key. Next slide. So again, these are just some of the workup that needs to be done in a patient with pulmonary hypertension, and echocardiogram is something we did in this patient as well, which confirmed the pulmonary hypertension. That's usually the initial workup, and then you follow that up with pulmonary clinic and continuous monitoring. Just a couple of learning objectives that I want to kind of emphasize on this patient is that again, teamwork as we need to be kind of doing in this kind of scenarios is what we did. Is like communication with other physicians, kind of discussing cases and taking input from everyone to kind of care for a patient such as this who is not kind of getting better or kind of not recovering the way we want to. And I think that was the key in this patient. We had a tremendous team working with us, including our critical care team, and not being afraid to reach out to other individuals to kind of see their point of view. Any questions?
Just a quick question to be mindful of time, but do you think the patient had some underlying heart failure given that you guys treated her with diuretics and the BNP was so elevated?
So I don't think the patient actually had heart failure. I think it was just a pulmonary hypertension secondary to type 3 pulmonary hypertension. I think it was more of that causing the overall increase in BNP. So initially we thought it was possibly a component of heart failure that we were diuresing, but I think the diuresing actually backfired to the point that the patient became more hemodilated. So I think it was more of a pulmonary hypertension and erythrocytosis secondary to the COPD.